Yeah, we are ready. Vishal and I are ready. We just did a sprint over to room 6, and thanks to our dynamic team, we're able to get the patient up and ready, Ajit. So we've got Mark, our nurse, who I didn't introduce last time. I apologize. Elizabeth, our nurse, again, who has also come back from Florida to help us with this. Mark obviously took his weekend to be with us like the other nurses. And of course, we have Cristobal, Freddie, and the entire AV team here. So we've got a case here, and thankfully so, it is not as complicated, but yet there's a lot of good decision making that we're going to need. So let's go ahead. Excuse me, our team. Vishal Kapoor to my left, as everyone knows, and Michael Sola, who also sprinted over. So Mike?
Thank you very much. Next slide. We have a 75-year-old woman who presents with a non-healing wound on the right toe. It's for grade 3, category 5, and Wi-Fi stage 3. She underwent prior intervention. The right posterior tubular artery now represents for intervention of the right AT occlusion due to continued poor wound healing. She had standard risk factors, no past medical surgical history, on great medications for comorbidities, and elevated A1C, and slightly above base appropriate to LDL. Next slide. As you see here, she has a severely reduced ABI on the right side and a absent distal AT waveform and velocity. Next slide. This was her prior intervention, the previous PT. You see here, she had a PT occlusion. Ongoing. With great results.
So we put bioresorbable stents all the way down. And the reason we did the PT was we thought that the ulcer was in sort of the watershed area with more towards the posterior aspect. So we decided to do the PT. Thanks, Mike. She went home. I know it looks like a neuropathic ulcer. Ajit saw the patient. We evaluated the patient. We offloaded the patient. She did not heal. So therefore, we decided to bring her back and do the AT. Obviously, this is something we might have given more time if we didn't have to do this, obviously, with the conference, because we had a lack of, we lost a couple of live sites. So we brought her back a little bit earlier than we normally would have. But the wound is still, as you can see, is still dressed, and it's still not healing. So you can see the bioresorbable stents in the posterior tibia are gorgeous, as Sahil and I and Brian firmly believe in. And you could and Eric, and you can see here that we lined her with, I believe, four or five, I can't remember, bioresorbable stents. There's no SFA disease. Then in the below knee, you can see here that the posterior tibial does fill. Oh, here's the bifurcation. Again, no significant disease. And then you can see the AT is subtotal. And I'm so glad that it was, and so was Vishal. And you can see here that the AT flow is, again, it occludes distally. And then at the level of the foot, and you can see why we thought this would heal, you have a wonderful flow with the posterior tibial, but the great toe is not really well filled and not really well perfused. And I'll show you the next picture. But you see the anterior tibial does come back, or dorsalis pedis does come back at that level. So here's another picture of it. So Ajit, so what we did was we crossed very quickly with a gladius Mongo wire. Again, it wasn't a big deal to cross at all. There was a couple of areas where it was a little difficult. Here's a Mongo with a support catheter going in, Mongo at the level of the foot. We were not able to advance the catheter any further, so we had to do a coronary balloon. I'll show you the coronary balloon, a 2O coronary balloon. And that was the regular balloon, and then we went with a coronary balloon. Where is the coronary balloon?
It's coming.
The next one?
It just plays the loop. So
it plays the loop. So the coronary balloon was very tight to get in there. And you can see we were able to cross the coronary balloon across with the wire. Then we went ahead and ballooned the distal. I'm going to skip to the chase here. It says balloon angioplasty. And then we took a picture, and now you'll see why it wasn't healing. You see that the dorsalis pedis clearly extends into the great toe. And so now we've decided to go ahead and intervene on this. And it's also got a lot of foot disease. So I'm curious to see what everybody would want us to do. So I exchanged out my wire, excuse me, for a coronary run-through wire. And then we did an IVUS.
Can we play the IVUS?
Can we play the IVUS, guys?
1 second, I have to see the IVUS. Okay. Good. Chris, go back. Yeah, scroll a little bit higher up. Yes, perfect. Play.
So this is coming all the way from the dorsalis pedis in the foot. So Vishal, you want to just describe it?
Yeah, so you can see it's this diffuse disease all the way around with some calcification at specific spots, especially at the number 10 where we had an issue with filling up. But again, it's not that significant 360-degree arc, but there are segments anywhere from 90 to 180 degrees, intermittent. That's why we were able to cross, there it is, that was the segment right there at 10. That's why we were able to cross this subtotal occlusion relatively easier as compared to other cases. But again, diffuse disease all the way around from the prox to the distal with areas of segmental calcification, not severe, but I would call mild to moderate if you have to. And the sizing appropriately, as you can see, distally it's a 3.0 size. Proximally we measured almost all the way to 3.7540.
So the problem here, Jit, is that, okay, now you've got in the foot disease, you've got a diffuse SFA, and the idea is, what do we do? I mean, are we going to do scaffolding into the foot? No. How are we going to deal with this, and what's the right way to do it? Do we do atherectomy? Do we don't? I'm just kind of waiting. Me and Vishal have our ideas, but we want our expert panel to help us out with this one.
Yeah, no, I think it's a great case. And number one, I'm happy for you that this one was a little easier to cross. But yeah, I think this is a different case, right? Because you're talking about a disease that goes much closer to the ankle. And so, you know, that's one of the limitations of the bioabsorbable scaffolds. So I'd be curious to open it up to the panel in terms of now that, you know, the lesion's crossed, you see the IVUS here, you see some calcium there, but how would you kind of prep this vessel, and what would be your definitive therapy? Would you use IVL, atherectomy, and so forth? So maybe I'll open it up. Dr. DeRobertis, I don't know if you have.
Yeah, I think, you know, obviously, as PK said, a lot of us are using bioresorbable scaffolds to an increasing degree, and they certainly work. They work in the ways we tested them in the trial, in the Life BTK trial, but we didn't put them in the distal third of the lower leg, and so that's really the limitation, at least as they currently stand. We don't know how they will do there, and I suspect ultimately, the winning strategy will be a combination of maybe scaffolds proximally and DCBs distally. So that's of course why we're hoping some of these current trials will help out. In this case, with what's available, I would say probably I'd do balloon angioplasty. I don't see a lot of need for IVL necessarily there, but I'd say balloon angioplasty is probably one vessel prep technique. Alternatively, you can use various balloons to help reduce your risk of dissections, Serenator or some other scoring balloon that would help prevent dissections that would obligate the need for a scaffold.
Would anyone consider, is there a role for atherectomy in this case when you're going this close to the ankle, or would you avoid it in this scenario?
I mean, I've done it. It's not my favorite location for atherectomy, and I don't think you need it in this particular case. I think the risk outweighs the reward. So I would probably lean more towards a specialty balloon. Mm-hmm.
Yeah, I agree as well. I would not do atherectomy in this compartment. There's some calcium there. I fear that without being able to put a filter down there and do atherectomy, we could shower some debris and make things worse. Okay.
Yeah, so I guess what we're hearing is maybe a specialty balloon, and then probably no role for atherectomy here, just not worth the risk. What are your thoughts, PK? What are you thinking about?
Well, I'm worried about vessel prep. I'm curious what our European colleagues have to say as well. For me, Vishal and I saw the IVUS, saw that it was a diffuse plaque burden with some minimal calcification. So we were kind of leaning towards atherectomy, but I'm curious what Dr. Ducasse as well as Dr. Brodman would have to say with their experience, obviously.
Dr. Brodman, Dr. Ducasse, any comments on would you do anything differently?
I mean, if I can start, I would do vessel prep with maybe the Serenator. I think that would be my primary choice. And then I would like to ask the question if you have the micromedical stent available here, because we had some kind of really good results using this in the trial, especially also for below the ankle scaffolding. So really good experiences.
Yeah, I mean, I think this just kind of highlights why this is such a challenging location, right? When your prior case, it was a more proximal lesion, so you had the scaffolds, you had more options. Once you get by the ankle, you're really limited in, what you can do, which is one of the challenges here. Does anyone have any experience of putting a Sprees closer to the ankle, or is that just something to avoid?
I have done it. I try to avoid the part of the AT and the PT that has a lot of conformational change when you flex and extend the ankle. If you do an angiogram with those maneuvers, you can see that the PT, for example, straightens out quite a bit when you dorsiflex, but when you plantar flex, it takes a sinusoidal shape. So that's why I try to avoid that area. If you needed a scaffold, again, this would be off-label to do down there, but the first thing that does break down are the interconnecting bars between the rings. So I think stent fractures, although I'd be concerned about that, they're probably less of a concern than in a Zion stent or a other DES type stent.
Okay.
Who knows? I mean, they actually may be effective, but we certainly haven't tested them there.
We're kind of going to buck the panel here, Ajit, and Vishal and I are going to stick with our plan. We're going to do directional atherectomy of the proximal, and then we're going to go ahead and do what is it called? A serenader to finish this, and then maybe spot scaffold. I don't know what we're going to do. Can you go Ario for me, please?
Yeah, coming out.
Yeah.
So since we weren't subintimal anywhere, I want to take out the bias, and I just want to daughter the vessel first. And then I know there was no occlusive disease here, so I'm going to start right about here on. And then just go very, very slowly with the directional atherectomy.
And then
About the length of the nose cone off.
PK, what type of directional atherectomy device is this, and how do you kind of choose your sizing between? I guess it looks like an EXL to me, but do you ever use DS if you're going close to the ankle, or how do you decide?
Definitely in this lady, a DS would be a good idea off. But I don't want to go too much past, say, 10 here. I don't know what Brian has a lot of experience like we do. I don't know what his thoughts are, but I'm going to try to go a little lower on and then take a look. I know it's a very small vessel here, but I know I'm going to get my maximal luminal gain at this area off. Show me down. So at this stage, nope.
Sorry, is that the EXL?
Go ahead. Yes, it is, Brian. On.
Yeah. I think excisional is a good option for the proximal tibials. I don't use it quite as much in the distal tibials, but the EXL certainly can go all the way down. And as you mentioned, DS, you can go with the DS all the way.
Let's go with DSA here.
Yeah.
The other maybe
Take
potential
one shot. We
advantages.
only do one pass and take a shot.
Yeah. The other potential advantage is maybe if you can debulk it a little bit, you'll get a little better luminal expansion by the ankle, which would help, since you can't really put in a scaffold there, or you'd probably choose not to.
See, that's a much better looking vessel there.
Yeah.
Come a little lower. Yeah. And we're just going to take another picture here. Inject, guys. So the only question is, are we going to scaffold already? My administrator is calling me. I got 5 calls already. So I'm a little worried. I might have to call Brian and say, he'll say, please, guys, I need a job. But over here, you can see the flow in the foot is there. It's just that I have to get a little bit lower to be able to establish some more flow. So I may go down with this, but the problem is this is not quite reaching to that level. So maybe we get the DS device. Can you get me the DS device, guys?
PK, if I heard you correctly, I think you said you had 5 calls already, so your administrators must be pretty tough. That's more than 1 call per scaffold.
Yeah, on a Saturday.
Yeah, we don't get that kind of harassment.
You must really be in trouble since it's
I'm
a weekend.
joking. Oh my God!
PK,
all the calls are going to come tomorrow. Yes, sir.
PK, can you talk about your choice of? You obviously are a high volume operator with directional atherectomy. Is there any other atherectomy device you would use here? Laser, given that there's not a calcification, do you think that would be worth it? Is there any other device you could use?
We use all the devices in our lab here, Vishal and I, and Karthik and Raman. But I think in our hands, directional atherectomy, we're very conservative. We made 1 pass here. I'm keeping the atherectomy catheter ready if I need to make another pass. But I'm going to do the DS down below if they can find it, and then we'll go ahead and then evaluate with an IVUS and then decide on destination therapy. My goal here would be to get away with just some spot scaffolding if I can. Maybe I'll do a prolonged serenation, and then take it from there. If not, I guess we'll have to default and do the resort DRS again.
And then PK, how do you decide where to put your scaffolds? Especially if it's like a long lesion like this. Are you deciding based on the initial angiogram what looked the worst, or are you just going with your final angiogram and just centering it around those lesions, or are you aggressive and you'll just put in as many as you need and deal with the financial consequences after?
I think this case is not like the other case. I think in this case, if we can get good flow into that foot, this wound will heal. You've seen this patient, as you know, and she's improving. She just hasn't completely healed. So I think if we get enough blood supply through the DP, she's going to heal. So I think I just want to open that proximal area, and then if I'm able to get enough flow, I'll do IVUS to see if there's any significant recoil. And in the areas that there's significant recoil, I will do a spot scaffold, even though Brian and I we feel that definitely you need to have full lesion coverage. But I think in this case, the proximal area was not diseased. So I think we should be okay.
Okay, perfect. So maybe we'll let you do a little bit of work here, and then we'll do our next talk and then come back to you. So any updates on how it's going over there?
Yeah, you can go up slowly, guys. So we went ahead and did the DS into the foot. And then we, let me show, I don't know if we saved it, but we went all the way down.
We did.
Did we save it, Vishal?
Yes.
I don't know how to look at it.
Let it play.
Let that one play?
Yeah, no. The next.
Okay.
Yeah.
So anyway, so we went ahead and did, this is the EXL, but we also did the DS all the way into the foot. Oh, this is the DS. No, this is the DS.
Yeah, this is the DS.
Yep. So yeah, once we get it there, no, this looks like EXL. I don't know. I'm not sure. Anyway, we did this.
Yeah, it's the DS.
After this, we did the DS, and then we took a shot. And then you could see that there's a little bit of recoil at the level of that of the ankle. You can see the DP comes down nicely, the AT, and then at the level of the ankle, it recoils right above the crossing with the perineal. I know it's not a great angiogram. I apologize for that. And then you can see that the DP starts to fill. Then we went ahead with a 2025 long balloon. So the balloon was inflated, left up for about 2 minutes. You could see. And then after that, this is again the balloon inflation. Then we took another picture after the balloon inflation. And you can see the flow is pretty good. I mean, it's competing with the posterior tibial now, beating the perineal down. And now you're starting to see perfusion into the forefoot. So at this stage, we said, okay, let's go ahead and look at the proximal. So which we did here. Sorry. And you can see it's overlapped. I'm going to take a better picture. I apologize again.
The next is
so in the next picture, you can see that the proximal is recoiled. So now we're going in with a 3.0 Serenator distal and a 3.5 Serenator proximal, with the hope of just leaving this with the serenation and angioplasty, and then maybe having a discussion whether that's contemporary care in today's day and age. So Vishal is just going to go up with the Serenator now.
It's already up.
And we'll just let it percolate there.
So PK, we sometimes forget to talk about this during these live cases, but have you
ready to come down.
used any vasodilators? What's your vasodilator regimen?
Yeah.
Absolutely. So we use nitrite, nitro and verapamil. We also have nipride available. Generally speaking, nitro and verapamil we use in a cocktail, usually depending on after our work is done, to take a look, take a picture. In this case, after the balloon angioplasty, we did use nitroglycerin to go ahead and take a picture, and there was significant recoil. You can walk it back, guys?
Yeah.
So now we're just, it's serenation distal. Yes?
We start at 5.
Yeah, I think that's a great point, though. Right, because the flow is a lot better than it was before, but the PT is still out competing
take it up.
So you got to imagine it's probably not the inflow. Looks like you created a decent channel, so it's probably the outflow would be my guess. And then, especially with your wire down there, you got to think about spasm, things like that. Sometimes you can take a catheter down and take a picture and see if you embolize or if it's spastic. That's another way to kind of assess the flow. So you chose a Serenator
that's
here?
Exactly what we're going to do.
Okay, perfect.
Yeah, this is a 3.0 Serenator. We have a 3.5 open. We're going to do 3.5 proximal, and then we're going to go down with give some nitro and take a good picture. And then we'll come back and do an IVUS while you guys are talking. And if there's any areas of recoil or dissection that's significant, we may go ahead and place a scaffold or maybe a coronary DS. I'm not sure.
And then,
I just wish we had the DCBs. Would make our life easier.
Does the outflow impact your choice on using a bioabsorbable scaffold? If you have like poor runoff, would that change your algorithm?
Oh, definitely. I mean, if I had poor runoff, I definitely would not use a scaffold. I don't know what the panel thinks, but I probably wouldn't.
PK, tell me about sizing. You know, I noticed 3.5 proximally, 3.0 distally. I think some would say that's a little large for a tibial vessel. I agree with you that I think that's the right size. I think we chronically undersize our balloons, but there are sometimes reasons to do that. Do you use IVUS? Do you use your pre-dilatation balloon? How do you size tibials most of the time?
The IVUS was sized distally, Brian, at 275, so we just went with the 3.0, and since it's a Serenator, we felt that we could be a little bit more comfortable with going a little bit larger. If we were just going, when I did the plain old balloon angioplasty, we did a 2.0, 2.5 in the distal. So I think that because of the mechanism of action of these balloons, we decided, Vishal and I, to go ahead and be a little bit more aggressive. I hope we don't regret it, but that's what we decided.
Yeah, one thing, Prakash, you opened up the PT in the past, didn't work. There was nothing getting out to the toes. You really need to keep this open. Sometimes what we do is it's a limb salvage situation. If you have to scaffold across the ankle, you don't want mobility, you immobilize the foot, put them in a cast, get it to heal. And whether it takes weeks and weeks, but you salvage the limb, you're going to be anticoagulated anyway in terms of DVT risk, so it may be an option for you.
No pride.
Yeah, I mean, that's the beauty, is, I'm very blessed here to have our relationship with vascular surgery and vice versa. So we'll take a good look at it, but I think obviously I agreed with you, Al. If there's not good flow,
100.
Then we're not going to hesitate here to put a scaffold. I've never actually casted him. I don't know if Ajit has, or I know you have. Obviously, I don't know if any of the doctors have. How do the patients accept that? Do they accept it, or do they fight you?
I mean, I haven't personally had to do that, but if it's the choice of an amputation, I would imagine that if that's their only option, then you'd have to kind of advocate for it. But I do want to keep us on time, so I'm going to move on to the last talk of the session, PK, and then we'll come back to you to kind of recap here. PK, we're turning it back to you just to wrap up the session here.
Yeah, that's great. So look, I mean, I want to show you guys our IVUS here. So as Vishal goes through, maybe he's not going through here. There he goes.
Okay. Go slow.
So I'm going to stop there for a second. I just want to show you what happened. So we did the 3.0 and 3.5 Serenators, like we talked about, and then after the Serenator, we took a picture. Let me show you. I think this should be it. Nope, this is before. And we did the Serenators, and this is the IVUS. IVUS showed a dissection and recoil around 10. Can you show the IVUS, or the first IVUS, please? The second IVUS, yeah. This one. Play this one.
Yeah, we haven't done the IVUS yet.
No, you did one after the Serenator.
Yeah, this is the one.
So you can play this. You can see here that distally looks really, really good. And you can see as you come forward around 10, where the calcium was there, that there's a little bit of a recoil. And then you'll see the mark will come very, very slowly. We're doing a very slow IVUS here. And there, right there. I think there it is. There it is. Little recoil, and there. And now it goes back to being a beautiful vessel. So go back to angiogram, guys.
Where is that recoil,
so
PK?
we did it. Right at 10.
We're going to see a picture.
Where's the angiogram? We didn't have an angiogram of that?
We should. No.
We should, right?
Yeah, go forward. That's the IVUS.
That's now the scaffold, isn't it?
No, that was just.
This is the IVUS. Where's the angiogram?
Go next.
This must be the angiogram. This must be the angiogram. Okay, here's the angiogram after the Serenator. Nope, one before this. Sorry, guys.
At 10.
10, I know. So it should be the next one.
One before that.
One before,
yeah. This is it.
Here we go.
You can tell the flow already looks a lot better. Feels at the same time as the PT does now.
Oh, yeah? Is it playing?
Hold on, let me play this one.
Nope, maybe the one before this.
Yeah, play this.
This is the one. Sorry, guys. So you can see
now
here, now you'll see the area of where the IVUS didn't look very good, right around 10. So everywhere else looked really, really good. So since you guys were talking, we made a command decision here to put a spot bioresorbable. You can see the flow into the foot was not really good. The AT does come down, but you don't see the toe very well. So we said, okay, let's put the bioresorbable in, which we did right there. It's the IVUS. Okay, there's a bioresorbable. Right around 10 to 11. We sized it as a 3.0. And we went up to obviously post-dilated. And then we did a picture of the foot. Now you can see the improvement in the flow all the way out to the toe.
Yeah, that looks great.
So which is exactly what we wanted. And then proximally, obviously, we just have the good looking vessel with no issues at all. So you can see this is the proximal AT with no dissection angiographically, good flow, with a spot bioabsorbable, which honestly I don't like to do usually. So, but I think in this case it was appropriate.
Yeah, and I think now that your
So with
flow is a
that-
lot better, I think that's going to do just fine. But that's a great result, especially with what you started with. All right.
And
Any
also,
final comments?
It was a different kind of case.
Yep. All right. I think I got to get everyone to lunch. So great case, PK.
Thank you. See you guys soon. Thank you, guys.